Good evening, everyone. Thank you for joining us for our Dean Speaker Series on Innovators, Changemakers, and Arc Benders, where we're featuring some of the leading thinkers and changemakers of our time whose work has helped transform public health. My name is Michael Liu. I'm the Dean of Berkeley Public Health. And for this conversation, I'm pleased to bring together a panel who truly exemplify the title of the series, Innovators, Changemakers, and Arc Benders in public health. All right, I know that some of you are probably asking, what's an arc bender? I know you get innovators and change makers, and some of you might even know about air benders and water benders, but what's an arc bender? What speaks to the fact that the arc of the moral universe is long, but it bends toward justice. The problem is that the arc doesn't bend by itself. Somebody's got to bend it. All four of our panelists exemplify what I call arc benders. They spent their life bending the arc of the moral universe toward justice. And all four of them have played a pivotal role in advancing an idea that is inextricably tied to social justice. The idea is social determinants of health, defined by the World Health Organization as the conditions in which people are born, grow, work, live, and age, and a wider set of forces and systems shaping the conditions of daily life. It's an idea so powerful that it has transformed the fields of medicine and public health and continues to shape health policy making here at home and around the globe. In fact, a few years ago, when I was testifying before the House Ways and Means Committee on the high rates of maternal mortality in the United States, the late Congressman John Lewis asked me, Dr. Liu, what are we going to do about the social determinants of maternal mortality? As Dean, I'm truly proud of the role that Berkeley Public Health has played in giving rise to the idea through the pioneering work of some of our faculty and alums like Len Syme and Sir Michael Marmot. They aren't able to join us on this panel today, but I'm truly grateful to be joined by other faculty, alums, and friends of Berkeley Public Health who have helped take social determinants of health to the next level. We got a lot to talk about today, so I won't read their bios, but I'll just say that they are among the people I admire the most in public health, and I'm truly grateful for their friendships over the years. With us today in alphabetical order are Dr. Paula Braveman, Professor of Family and Community Medicine and Director of Center on Social Disparities in Health at University of California, San Francisco. Dr. Braveman is a member of the National Academy of Medicine. Dr. Tony Iton is the Senior Vice President for Healthy Communities at the California Endowment, former Director of the Alameda County Department of Public Health, and I'm proud to say a faculty member at Berkeley Public Health. Dr. Ichiro Kawachi is the John L. Loeb and Francis Lehman Loeb Professor of Social Epidemiology at the Harvard T.H. Chan School of Public Health, who, along with Berkeley Public Health alum Lisa Berkman, co-edited the first textbook on social epidemiology. Dr. Kawachi is also a member of the National Academy of Medicine. And Dr. Mahasin Mujahid is the Chancellor Professor and Aldous Chair of Public Health at UC Berkeley School of Public Health, whose research is devoted to examining neighborhood health effects, cardiovascular health disparities, and racial ethnic inequities over the life course. Well, thank you all so much for joining us this evening. We'll have a conversation for about an hour, then open up for audience questions. If you have a question for our panelists, please go ahead and type them into the Q&A, and we'll try to get to as many of them as we can. So let me start with a question for all of our panelists. For those of in our audience who may be less familiar with the idea, what does social determinants of health mean to you? And how can you draw an example from your own work to illustrate how social determinants affect health? And let's go ahead and start with Paula.
Okay, I think it's great to start by getting clear on what we're talking about. And the concept of the social determinants of health, and please, my colleagues, correct me if I'm wrong, but it emerged in the largely in the 70s and was a reaction to the total obsession with medical care. And it really, what the term meant was the social factors apart from medical care that have important influences on health. So social factors like the adequacy of one's income, the adequacy of one's housing, childcare, nutrition, neighborhood conditions, all of these factors that are under the control, ultimately are under the control of social policy. There has been a little bit of confusion, and the WHO Commission is partly responsible for that, but I think I understand why they made a decision to include medical care among the social determinants. And my understanding is that the reason is that they felt that the funding for the most basic medical services in developing countries was just so low that it was a real strategic error to leave that out. So you may see, someone referring to the social determinants of health, including medical care, but that's most of us, and those of us who work in the field, this was differentiating the social determinants from medical care.
Great, thank you, Paula. Tony, anything else you want to add in terms of further defining, clarifying the concept, and also maybe offer an example from your work to help illuminate how social determinants impact on health?
Yeah, I have a lot of examples, and first of all, it's a great honor and privilege to be here. I'm more of a practitioner than an academic, although I hang out with a lot of really awesome academics, such as the folks on this panel. And, for us, the question has always been, where is health generated? What is the source of health? And in this country, too often we think of health being generated in the doctor's office or in some sort of transactional exchange between, individuals and professionals. And what we've recognized, and I think what most people who actually are charged with trying to figure out how to improve health, is that health is actually generated through opportunity structures that are in community. And some of those key opportunity structures are things like, the quality of education, the quality of land use systems, the quality of the health system, quality of the criminal justice system, and the interactions that people have with those systems essentially can either be positive springboard interactions where they're maintained in a high trajectory, or they're kind of almost like tar pit interactions where they're kind of clawed down and pulled and scarred and scratched and struggle to emerge on a high trajectory. And so those conditions, as Paula says, are really, the product of policies. And so I could go through any number of examples where this is an issue, but one of the ones that was sort of most striking to us early in our work was when we looked at how our education system was performing in California, particularly for Black, Brown, and Native American boys. And we saw very early on that some 800,000 young people were being suspended and expelled from schools in California every year. And those interactions were essentially pulling down their life trajectories because we could show through correlations that a single suspension before 9th grade reduced the likelihood of graduating from high school by 30%. And we know that high school graduations, and in California, the ability to acquire the so-called A through G requirements, which allow you to matriculate at UC Berkeley or in a Cal State, a 4-year university. Those are absolutely critical. And we saw that when we looked at this population, only about 11% of them actually emerged from that pathway of high school into eligibility to matriculate in a four-year university in California. And those kids, those are the kids that have a shot at having a meaningful role in participating in the 21st century economy. So it's just sort of a stark example that the education system was performing so badly that hundreds of thousands of kids were getting expelled and suspended. And the percentage that actually could make it through what we consider to be a sort of a modest milestone in education, which is a high school education with the ability to matriculate into four-year college, was so low that, you know, close to 90% of them weren't making that.
Thanks, Tony. And certainly later on in the discussion, I want to make sure that we take a deeper dive into what we can do about social determinants. But let me turn to Ichiro and Mahasin first. Ichiro and Mahasin, anything else you want to add, both to the concept definition and also examples from your work in terms of how social determinants affect health?
Sure. So good evening. Michael, you mentioned at the beginning Sir Michael Marmot, who is a distinguished alumnus of Berkeley. And as a young medical student, one of my earliest epiphanies was reading his British Whitehall study. It was a famous study of British civil servants. And the shocking thing to me when I read the study as a medical student was that even though everybody in the British civil service had the access to the National Health Service, over follow-up, they found a fourfold difference in survival between people in the top civil service grade compared to those at the bottom. I truly think that British people, when they established the National Health Service after the Second World War, they truly believed that all health disparities would be eliminated as a result. And yet, 30 years later, here's this fourfold difference in mortality that truly shook me up as a medical student. And that's when I first started to get an inkling about something else out there, which I kind of think of as epidemiological dark matter. There's an epidemiological dark matter out there which explains health disparities that cannot be accounted for by access to health care. And it's in the sort of lifelong pursuit of trying to understand what that dark matter might be, which has led me to conclude that it is the conditions of life as defined by the World Health Organization, the conditions in which we are born, we live, we work, we grow, we age. So social determinants for me is almost everything around us. It's the quality of our neighborhoods, of our schools. It's the quality of our food environment, housing, working conditions. So it's really everywhere around us that, except for things like genetics and medical care. So that's been a lifelong pursuit for me.
Thank you, Ichiro. And Mahasin, I know you've been doing some of the most groundbreaking work in this area, in this generation. So Mahasin, anything else you want to add to the concept and maybe draw an example from your own work?
Sure. First of all, thank you for the invitation to be a part of this panel. There's such a fantastic lineup of thoughtful leaders. I guess for me, social determinants of health provided early on in my career an opportunity to acknowledge that health is more than a function of genetics and biology, that it's not predetermined, it's not innate, which were really impactful in my career. But also, more importantly, that it's a function of inequitable systems and practices that unevenly distribute health-enriching resources and hazards throughout society. And so having trained as a social epidemiologist, I was provided with language and definitions and theory and frameworks that gave voice to my lived experience, as well as a scientific approach to really understanding the impact of that lived experience on health inequities. And so an example from my research, I do a lot of work on how neighborhood physical and social environments impact cardiovascular risk. And so using data from leading cardiovascular cohorts, such as the multi-ethnic study of atherosclerosis, I've worked in concert with many other scholars internationally to contribute to a body of research that sort of work to develop neighborhood measures, improve their measurement properties, link them with cardiovascular outcomes, and understand the mechanisms linking them to those cardiovascular outcomes. So to provide a concrete example, we've shown that features of the physical and social environment, so things like availability of healthy foods, opportunities for physical activity, safety, social cohesion in the neighborhood, that those are associated with Life Simple 7, or the very health factors and health behaviors that have been adopted by the Centers for Disease Control, by the American Heart Association as being most critical to improving heart health, that these things are in fact shaped by neighborhood context.
Great, thanks so much, Mahasin. Let me ask a follow-up question for all of you, just using the more recent example to help illuminate the idea of social determinants. So how do social determinants explain the disparities that we've been seeing in this country in COVID infections, hospitalizations, and deaths? Let's see, Paula, we'll go to you first.
Sure. Social determinants pretty fully explain the social disparities that we see in COVID infections, hospitalizations, and deaths. It's like, who is it? So who is it who's more likely to be exposed? You know, it's not the people like us who can work from our home offices. It's the people who have to take public transportation and go in and work in a crowded, restaurant back. There's more for people who have fewer economic resources. There is more risk of exposure, but at the same time, there's also more risk of vulnerability to getting sick when exposed. And that vulnerability, part of that vulnerability comes from the chronic stress of trying to cope with daily challenges with inadequate resources. Now we know, neuroscientists trace the pathways, the neuroendocrine processes, so it's not, what can I say? It's not voodoo anymore to be talking about how the chronic stress gets under the skin, and why that chronic stress is inequitably distributed, both by social class and by race, and then you have the added chronic stress of experiences of racism that just sort of pile on to the chronic stress of economic struggles, and you've really affected the biology of the person and their ability to fend off an infection if they are exposed. And then, of course, that the vulnerability determines who gets hospitalized and who will die. But it's a kind of a textbook case of how inequitable distribution of the resources and opportunities in a society, how those result in these patterns, these horribly disparate patterns of infection, hospitalization, and death.
Thanks, Paula. So it's really not just access to testing and treatment. Tony, Mahasin, Ichiro, other things you want to add about what's going on with the disparities that we see around COVID?
Or,
Yeah, I would
so,
just add that, in much of what I learned about the effect of racism and health, I learned from Paula Braveman. I've just been privileged to learn it. I would add that, I had the privilege, I guess, of co-chairing the Oakland Alameda County COVID Disparities Task Force over the past couple of years. And one of the phenomena that we saw in the epidemiology, which was really kind of striking, was profound disproportionality amongst certain groups of people, but really profound disproportionality amongst one group of people in the Alameda County area, as well as the rest of California, which were, in the data, it described them as Latinos. When you actually bore down and looked at who these folks were, these were non-English, non-Spanish speaking indigenous Californians. In other words, indigenous immigrants from Central and Latin America. And these folks were doubly and triply vulnerable. And so the concept is we place people in harm's way through policies, or more often it's the absence of policy in the face of abject need, which some of us refer to as policy violence. We place them in harm's way. And these folks could not follow any of the guidance that was coming from the health authorities. They needed to work, and they needed to work every single day. They were living in circumstances where they were oftentimes sleeping in shifts amongst many other people who were similarly situated. If they got sick and told their employers they were sick, they lost their jobs. So the advice they were giving to each other was, don't get tested. If you get sick, just fake it, pretend you're well, and work through it. And we heard this from the groups that were serving these people. And when you think about what they were saying to each other, it was entirely rational. Yet what we were telling them was, isolate, in your home, take time off work remotely, get tested. And all of that was irrelevant to them. And that is because we place people in harm's way. We make it impossible for them to essentially follow the advice that we recommend. So for me, COVID-19 just ripped off the cover of that sort of genteel notion that we have equity in this society. We take people and we put them right in the face of a speeding truck, and then we feign surprise when they get run over.
Great, thanks, Tony. Ichiro?
Yeah, so as Paula mentioned, COVID is a textbook example of the social determinants of health in action. Speaking of textbooks, the textbook that I'm working on right now with Dustin Duncan and Stephen Morse at the Columbia University is a new textbook on the social epidemiology of COVID-19. One of the things that we realized was that as we scan the table of contents of the textbook that I edited with Lisa Berkman and Maria Gleemore, you could go through each chapter, the chapter on social class, on race, on income inequality, social capital, neighborhoods, immigrants, working conditions, and basically you could just append, this and COVID to each of the chapter titles and say something about the importance of social determinants in explaining COVID-19 outcomes. But the really interesting thing, as Tony said, the inequalities that we have seen should have been completely predictable, knowing what we do about how social determinants pattern people's vulnerability to illnesses. So long before COVID, these disparities were already amply evident. But as we sort of write this book, the other thing that's becoming evident is how the pandemic itself is changing social determinants of health in ways that will affect population health for years to come. We think about how there will be lasting impacts of remote learning on child development by social class, or permanent changes that are happening to working conditions and the nature of work, or the erosion of trust that we're seeing as a result of the way in which the pandemic has been politicized. I hope we'll have an opportunity to discuss some of these things, but it's obvious that social determinants determine pandemic outcomes, but the pandemic is also changing social determinants in ways that we need to be able to anticipate and mitigate.
Thank you, Ichiro. Mahasin?
Sure, and I would just add on to that. I love this theme about how COVID-19 is sort of this real world, real time example of social determinants. And I would go a step further and say that one of the theories that I teach often in my class is Lincoln Freeland's fundamental causes. And I think that what COVID-19 is actually providing us an example, a concrete example of how fundamental causes operates. So briefly, fundamental causes is a theory that articulates social factors as fundamental causes because they're associated with multiple disease endpoints. They're associated with these endpoints through multiple mechanisms. They're tied to money, power, resource, opportunity structures. And most importantly, these associations are reproduced over time because if we eliminate all of the disease-related risk factors, a new set of risk factors would emerge. Those risk factors will become socially patterned, and then the inequities are reproduced over time. So in the case of COVID, which we can consider to be this sort of new risk factor, we're seeing this risk factor is socially patterned. We know that racial, ethnic, and socioeconomic marginalized groups are disproportionately impacted by COVID-19 hospitalizations and deaths. But we also know now that there's growing concern over long COVID. In fact, there's been a recent call by Representatives Ayanna Pressley and Don Bayer to release data on long COVID by race and other demographic factors. And because if there's this new evidence emerging that long COVID is associated with increased risk of cardiovascular disease and other chronic outcomes, then if long COVID is also socially patterned, then again, a new risk factor emerges, it's socially patterned, and therefore disparities are exacerbated and reproduced over time. So I think we're also seeing sort of fundamental causes play out in real time with COVID.
Great, thanks so much, Mahasin. I want to do a deeper dive into what you all just said and also your life's work. And let me go to Paula first. Paula, Mahasin just mentioned the idea of fundamental causes, and certainly you've been one of the most vocal champion of the idea that it's really time for us to be considering and tackling the causes of the causes. So if you could talk to us more about that, and what do you think some of the most important causes of the causes are?
Sure. First, to say that I don't think I'm the first one to come up with the phrase. I thought it came from Jeffrey Rose, but I haven't been able to find it in anything of his. And so if anybody knows about the use of that term before 2014, I guess is when I first published about it, please let me know. But I love the concept because it's I mean, the notion is, we're so used to just looking at the immediate cause, the downstream cause, and not what is upstream or fundamental, as Mahasin was talking about. And so that sort of injunction to always go for the causes of the causes. And so, for example, there are so many people who believe that obesity is, the major cause of ill health, and some victim blaming along racial lines is sort of added into that. So do people question then, where does obesity come from? What about the neighborhood conditions that have been shown to foster obesity or not obesity? obesity, normal weight. We know that food insecurity is associated with obesity. Perhaps it seems somewhat counterintuitive, but the idea is that if you're food insecure and you don't know you can't count on where and when the next meal is going to be coming from, you may gorge on cheap, high carb, high fat foods. The role of chronic stress in affecting eating behaviors, for example, and then with those causes, we have obesity over here, and then we have these things like chronic stress and neighborhood characteristics and food insecurity and a host of other factors there. Then do we ask the question, what causes those? And of great importance, I think, to everyone who's participating in this panel is, not only what causes those intermediate outcomes, but why are they patterned socially? What is the injustice that's driving the kinds of patterns that we see of obesity? When I think of the causes, I think of these long causal chains, long complex causal chains, and I think that's the way most certainly fundamental social determinants operate, is through very long, complex causal chains that don't play out over a year or two. It's over decades, and sometimes it's over generations. And when you think of just how long and how complex those causal chains, leading from the causes, the causes to the causes to their causes to their causes, it's actually amazing that there is so much literature showing relationships between those fundamental causes and health outcomes, because it must be so powerful in order to get through those long, complex chains and not get eaten up by the complexity. So that's how I think about the causes of the causes, but I think it's a very useful concept.
Yeah, and certainly I followed your work for a very long time, and in much of your writing, you follow the causal chain until you get to the fundamental causes, which always can point toward various forms of social injustice. And I think that's kind of why your writing has such a profound influence on me and on so many in our field, is that you talk about how health equity is inextricably linked to social justice. Can you talk to us more about that and how you have defined health equity as social justice in health?
Well, I think that health equity, so one way of defining it is that it means that everyone has a fair and a just opportunity to be as healthy as possible. But in order to do that, to have a fair and just opportunity to be as healthy as possible, this requires removing obstacles to health, such as the lack of access to adequate income and good housing and childcare, nutrition, et cetera. So I think that health equity, you can't achieve health equity, fully achieve health equity, right? We can deal with it as aspirational, but health equity requires social justice in the conditions that determine health. So I do see them as inextricably tied, and that if you don't, without broader social justice, just focusing on health equity, I don't know what that would mean. Would that be focusing on health equity? But if you're really focusing on health equity and really consider what everyone has been saying, everyone of this panel has been saying that it's the determinants of health. If you don't have equity in the determinants of health, how can you have health equity?
Thank you, Paula. Let me go to Mahasin next. Mahasin, I truly believe one of the most important causes of the cause, one of the most important fundamental cause is racism. So what are the ways by which racism can affect health?
First, let's start by defining racism. And I like to use the definition by Kamar Jones, in which he defines racism as the structuring of opportunity and resources and assigning value based on the social interpretation of how one looks. We refer to that as race. And that this process unfairly disadvantages some groups and unfairly advantages other groups. But most importantly, it saps the whole society through a waste of human resources. And so this system of structuring opportunity and resources based on race has led to the strong racial patterning of the things that we refer to as the social determinants of health. So all of the ways that social factors become embodied and lead to sort of health inequities are the same ways or represent the sort of trickle-down effects of structural racism and how structural racism is linked with health outcomes.
Thanks. And I know you've done some recent work on historical redlining, which is certainly an important manifestation of the ongoing impact of structural racism. So what is redlining? Is this something of the past, or is it still going on, though it's been outlawed since the Fair Housing Act of 1968? And how does it contribute to health disparities?
Sure. So redlining is a type of government-sanctioned discriminatory lending practice. And to be clear, there were many others that existed well before sort of the 1930s when we think about redlining. So this comes through racial covenants, it comes through deed restrictions, but nonetheless, the term redlining was referencing practices of the Federal Homeowners Loan Corporation, and they developed these HALT security maps as a process of sort of color coding areas red if they included high concentrations of Black or immigrant or working class residents. And they deemed these areas as hazardous. And because they were hazardous or undesirable, they were excessively risky for investment. And so these HALT grades were used to deny home loans. They contributed to the systematic disinvestment of redlined neighborhoods for decades. And so we can see the current day effects of redlining through sort of the legacy of redlining currently. And so to investigate this empirically, we recently conducted some analyses where we looked at this practice of historical redlining in relation to current day cardiovascular outcomes. And what we found is that individuals who resided in historically redlined areas, as well as the other undesirable areas, had a higher sort of occurrence of cardiovascular risk factors. So the health behaviors and health factors that are part of Life Cycle 7, those were higher among those individuals that lived in historically redlined areas. But these associations were limited to the Black participants in our study. We did not find it for any of the other racial or ethnic groups. And we also show that it was independent of the current day physical and social environment of neighborhoods. But I do want to note that improvements in the social environment is one clue about how we can sort of mitigate or lessen the impact of historical redlining, because we did show that the associations were weaker as the social environment of the neighborhood, the current sort of social environment of the neighborhood improved. And so is redlining a past? Sure, but does it have current day effects? Yes. And I think this is something that we received a lot of pushback on. We had journal reviewers sort of question our focus on historical redlining and encouraged us to just keep it about the things that are amenable to change, focus on the current day, physical environment of neighborhoods, the current day social environment of neighborhoods, tap into revitalization efforts, et cetera. And I think if we don't explicitly bring in the history, then we recreate those kinds of inequities based on this system of racism. And so what I mean by that is there's data to show, for example, in the Bay Area, that over 80% of the areas that are currently gentrifying are areas that were historically redlined. So we deemed these areas in the 1930s as being hazardous, but now we are sort of, you see groups that are reclaiming these areas. And that's also within the legacy of colonialism globally. And so I think we have to be really clear about how history is showing up, because if we aren't honest about it, then we're going to reproduce and sort of recreate the inequities that we're working so hard to tackle.
Thank you. Ichiro, you've done some of the most pioneering work on social capital and health. What is social capital and how does it affect health?
Great question. So social capital can be defined simply as the resources that individuals and groups can access through their social networks. Now, as a social determinant of health, the story of social capital is what I call, what I characterize as the good, the bad, and the ugly. And we've seen both sides during the pandemic. Earlier on in the pandemic, empirical studies show that communities with high social capital, those that are communities that are more cohesive, tended to do better in terms of adopting mobility restrictions, for example. And I think it's because through people's networks, social capital is believed to promote health through at least three mechanisms. One is through the faster dissemination of health relevant knowledge. Secondly, through the fact that more cohesive communities are effective in persuading individuals to adopt actions for the common benefit. And then lastly, because cohesive communities are more effective in coordinating collective action in order to assist members of the community in need. So at the beginning of the pandemic, we tended to see the more high social capital communities being better able to suppress infection, the spread of infection. As someone said, that communities that are better able to bowl together were more able to bowl alone as well by adopting restriction. But there's also a sort of a bad and ugly side, which is that as the pandemic wore on, we begin to see communities coalescing to protest things like mask mandates and vaccine mandates. And these protests, as you know, were organized in order to, as an expression of solidarity and political identity. And to my way of thinking, that is also indubitably an expression of social cohesion and social capital. So the lesson here is that social capital has this dual-edged characteristic. It is a kind of resource that is agnostic with respect to the ends to which it is put. But the overarching lesson here is that no matter which way you look at it, the good and the bad, social capital is an important social determinant of health that we need to understand in order to explain the things that are happening.
Great. And you've also done some of the most important work in income inequality and health.
Yes.
So is income inequality harmful to your health? And why in the wealthiest nation on earth, the United States, has poor health, even compared to less wealthy nations?
Yeah, that's a great question. So income inequality is another social determinant that has, I think, become quite prominent during the pandemic. I mean, as a general rule, societies with high income inequality are ill-prepared. They're ill-prepared to weather crises, whether it takes the form of economic shocks or climate-related disasters, or, as it turns out, pandemics. And the reason is because wider income and wealth gaps translate to a higher toll of morbidity and mortality from these crises. Because number one, even before the crisis happens, even before COVID-19 struck, unequal societies were already sicker. You just mentioned that the United States, despite being one of the richest countries in the world, is also one of the most unequal. And that makes us sicker compared to most other countries at the same level of economic development. We're almost in at the bottom of the OECD, and we have high level of morbidity and mortality because high income inequality implies that there's a large segment of the population who are living in fragile social and economic circumstances. And that's reflected in our high rates of morbidity and mortality. And so that made us very vulnerable to when the pandemic struck, to suffering from the serious consequences of infection. The same kinds of unequal distribution of social circumstances, whether it's housing security, food security, job security, all of these things translated into a dynamic which amplified the spread of infection. It's exactly as Tony told us at the beginning. We have large segments of people in fragile work circumstances, which is one of the signs of an unequal society. And that makes us very vulnerable whenever a crisis like this happens, and it amplifies the spread of infection. The other thing that income inequality does is that it makes societies less generous with respect to their social safety nets. There's a strong correlation between income inequality and erosion of social safety nets. An obvious reason is because high income inequality implies a very poor distribution of taxes, for example, less progressive taxes, which impoverishes the public purse in order to pay for a decent social safety net. And that makes societies like the United States less able to absorb shocks, such as happened when there was a large sharp economic downturn following the mobility restrictions that happened. And lastly, unequal societies are less effective in mounting a coordinated response to a common threat. And we've seen this over and over again in this country because of the social divisions that happens when there's a large gap between people with different levels of income. It equates to political polarization and the corrosive effect of free market ideology on the ability of the country to mount an effective and coordinated public health response.
Thank you, Ichiro. Let me go, Tony. Tony, you've been famously quoted for saying, when it comes to health, your zip code matters more than your genetic code. So as Senior Vice President of the California Endowment, you led a $1 billion place-based initiative to build healthy communities in 14 cities across California. What lessons have we learned from the past 10 years of doing place-based initiatives?
Thank you, Michael. And like Paula, I'm not sure that I was the first person who said that, but I've been saying it since 2004. So I don't know who said it before that, but in any case, what we decided to do at the California Endowment, and I think it was, I know it was quite radical. We decided to try to take what we knew about the social determinants of health and translate that into a practice to improve the health of kind of a large group in 14 communities across the state to measurably improve their health over about a decade. And the only caveat that we had was that we wouldn't invest a nickel in health care. And so it was a pure social determinants of health, initiative. And, what we came to learn from that experience was one, that the social determinants of health, when you're trying to apply them practically, are probably better understood as the political determinants of health, because they're fundamentally they're the products of policy and decisions. And so both Ichiro and Paula spoke to, and Mahasin with redlining. that this notion that policy creates conditions. And so, like Ichiro was talking about, those countries with a lot of income inequality have relatively weak social contracts. They don't invest in sort of like the overall well-being of their own society. And, I happen to have grown up in Canada, which has a relatively strong social contract: universal health care, universal childcare, universal paid sick leave, universal dental care for children. I mean, I assumed growing up that was how civilized countries organized themselves. They made investments in the well-being of their populace in anticipation of inevitable crises that people would experience. And the United States doesn't have a strong social contract. So the work of the California Endowment was really, in some ways, it was to try to reweave the social contract in California. And, to essentially take those political determinants of health, recognize that to strengthen the social contract, we needed to actually build the muscle of communities to hold systems accountable for equitable outcomes. So we wanted to make people better at politics, to essentially be able to improve the political determinants of health. And I think that the grand lesson from our work, we spent over $1 billion doing it, and we've pivoted to sort of deepen our commitment to that work. But one of the big lessons of our work, which was surprising to me, probably not surprising to most of the people on this panel, was that at the root of the sort of the weak social contract that the United States has is a narrative. It's a story about who belongs. And that story was really expertly told by our last president. He told one version of it, which was a narrative of exclusion, that some people don't belong. Some people are not deserving of the full benefits of society. And then there's another narrative, which is essentially our fates are inextricably intertwined, and our diversity is our strength. And we found that you can actually operate to strengthen the narrative, that inclusive narrative. And when you do that, it essentially leads to stronger and more inclusive policy. And that policy creates better conditions, more opportunity for people who had previously been viewed as, not belonging. So this idea of narrative begets policy, policy begets conditions, that's at the root of our work as practitioners at the California Endowment. And so after 10 years of doing this work and learning these lessons, again, distilling the brilliance of many of the academics on this panel and others into a practice to translate the social determinants of health into something that can actually be strengthened and built, we learned that you have to think about building, maintaining, and promulgating a narrative of inclusion. And that narrative changes the conditions for policymaking, and that policy then creates much more beneficial conditions through a stronger social contract. So going forward, we're actually just doubling down on those elements, on narrative, on building the infrastructure of power building across California, and making sure that we tie at the center of this racial equity. Because as Mahasin said, at the root of all of this is that it's a set of isms of which racism is the most potent. And racism is essentially what has shaped these competing narratives. This narrative of who belongs, who's fully human, who deserves the fruits of society. If we don't talk about that, if we don't build an inclusive narrative, we see the consequences of that. And many of us worry that the last president set us on a course which will ultimately lead to the dissolution of the fabric of our society because we don't see ourselves as being connected.
Thanks so much, Tony. I'd like to turn our conversation to what next, right? Because I think we've come a long way on social determinants in the last 50 years, but I think all of you would agree that we still got a long way to go. So what must we do differently in research, in education, in practice, in policy to advance health equity and social justice in this country? So let's start with research. And maybe we'll start with you again, Paula. What are some of the biggest gaps in our knowledge of social determinants of health?
Okay. I'd like to first slip in a comment that, responding to this great discussion so far, just that among the social determinants of health, we know that structural or systemic racism is among the most powerful and toxic, and we need to be dealing with that. So that's part of where the causes of the causes takes, in my mind, anyhow, that and gets people to think about structural or systemic racism, the racism that's built into the laws and the policies and the beliefs, so that even if no individual is consciously trying to discriminate, then it still operates very powerfully. And racial segregation is a great example of that. So what are what I think are some of the biggest gaps? Well, I think 20 years ago, 20 plus or minus, I'm not sure how many years ago, the question was, do social determinants really affect health? So you have a lot of research to show that these social factors do indeed affect health. And I think that we need to continue to document the force of social determinants, largely to inform political, basically political struggles. So we can't abandon that. But I think in terms of where the science is, the question is no longer, do social determinants affect health, but how do they do it? And most importantly, how do we interrupt the vicious, the vicious cycles? How do we intervene to turn it around into a more equitable direction?
Great. So let me ask a follow-up question for Ichiro and Mahasin in terms of study design for intervention studies. That certainly, when we're talking about intervention studies, randomized controlled trials have been the gold standard in our field for the last 50 years. But when you're talking about tackling social determinants, we're talking about multiple determinants that are at the individual, at the community, at the policy levels, and that sometimes may have to be done over a period of time and perhaps even a life course. So should randomized control trials still be the gold standard for how we intervene on social determinants, or is there a smarter and better way of designing research study that demonstrate to us what works and what doesn't in tackling social determinants of health?
Great question. So as a field in social epidemiology, I do believe it's important to take causality very seriously. But having said that, randomized trials should not be held as the gold standard. I think there was a very influential special issue of Social Science and Medicine a few years ago. It was put together, headed by an article by Angus Iton and Nancy Cartwright, who argued that it's mistaken to hold RCTs and put it on a pedestal. And the reason is because by the more narrowly we focus our questions on the so-called well-defined intervention, the further away we get from the systems and structures that we've been talking about on this panel, the systems and structures that shape population health. And so the more we do that, the more we tend to lose sight of interventions that may focus on the social, upstream, and system changing kind of things. And for that reason, I do believe that we need to think more cleverly of other kinds of study designs, taking advantage of natural experiments, natural policy experiments when we can, to try to understand how social determinants work. It's also impractical to conduct randomized trials on some of these very large systemic factors like income inequality. As Paula mentioned, many of these system-wide factors have long chains of causation, which are very difficult to pin down on a population-wide randomized trial. I know that, Michael, you're very interested in early life course interventions. I mean, think of the practicality of doing those. The reason why we see just a few true randomized trials of early life course interventions, because for the most, when you do these experiments as a researcher, you have to outlive your subjects. I mean, they take decades for the results to come in, and for that reason, they're seldom performed. And we need to sort of become realistic about what's achievable, and to be able to learn from other modes of inquiry, use the social epidemiological imagination, and study history. History, as Mahasin has been doing, trying to look at redlining, 50, 60 years ago, and try to detect its footprint on patterns of health today. So I think we just need to have a wholesale reassessment of what we mean when we say that we need to take causality seriously.
Great. Mahasin, anything else you want to add in terms of how we design intervention studies to address social determinants of health?
Sure. I mean, I think, the idea of natural experiments and other quasi-experimental approaches is really key. And I think one of the things that we're seeing, particularly in the kind of neighborhood health effect space, is that when we look at these kinds of natural experiments and the evaluations of them, we recognize that we still have many unanswered questions. And so part of what we tried to do, for example, was to isolate that the food environment was the critical kind of feature of the physical environment of neighborhoods that we should focus on for intervention, and that would lead to improvements in diet, improvements in obesity, improvements in sort of a range of chronic disease outcomes, dietary sort of chronic disease outcomes. And the results of those natural experiments were that, there were definitely improvements. There was increased neighborhood satisfaction. There was, sort of improvements in choice and quality and cost of healthy foods, but it didn't lead to the kinds of improvements in the hard outcomes that we were interested in. And I think one of the things that we have to understand is that in the research that we're doing, the observational research that we're doing, we need to really think about sort of going against these textbook examples of this independent effect. And in fact, we know that these things are not operating in a vacuum. There are sort of a clustering and synergies aspects of sort of both things that increase risk and that are also protective within neighborhood spaces and other, sort of place-based spaces. And so we need to make sure that the research that we're doing is going to better inform these intervention targets. And then the final thing that I'll say is that one of the things that often happens is that when we go through the very difficult task of sort of being magicians, that's what we have to do as social epidemiologists. I mean, we have the audacity to think, for example, that we can link historical redlining maps to current cardiovascular disease. The data are not there and ready for us. The studies that have the most rigorous outcomes don't have the depth and rigor to the social determinants. The data that we use to link to these studies are messy and complicated. But even when we're successful at bringing all that together, the patterns aren't always clear. They're not always linear. There's not always a nice, strong gradient. And sometimes the behavioral and the biological factors have the strongest associations in these models. And even though we know that these behavioral and biological factors are shaped by context and shaped by social determinants, in some ways, it sort of creates more evidence to focus on those individual and kind of behavioral and biological factors. I think the good thing, though, is that we're seeing that those interventions aren't working either. The interventions that focus solely on, diet, solely on sort of health promoting behaviors, that those aren't successful as well. The interventions that focus solely on drug therapeutics, et cetera. So I think that we have to think about sort of really expanding our ideas around these place-based multi-level interventions to really have the impact that we're trying to have in terms of health equity.
And Tony, how do we make academic research more relevant to communities and policymakers?
Yeah, well, I have notoriously been quoted as saying we don't need any more research, and that's not quite what I mean. What I really mean is that we need policy relevant research, research that actually allows us to sort of refine, implement, or create policies that are relevant to the social determinants of health, rather than sort of proving the same thing over and over again. So for instance, I think, Rand replicated a study of Elizabeth Bradley and Lauren Taylor looking at, per capita spending on social benefits, in addition to per capita spending on healthcare, on medical care, and showed that, those countries that roughly spend $2 on social benefits and services for every dollar on medical care had better health. And Rand took it a step further, and they went to look at each of the 50 states and showed that those states that invested on a per capita basis more on social services and benefits had better health. Understanding why that is, because what they showed was that the stronger the social contract at the state level, the better the health of the residents of that state. Trying to essentially disentangle that and understand what that is, that has immediate policy relevancy, because these are states that you can actually go and sort of copy their playbook and import them into another state. So that's the kind of research, at least for those of us who are kind of, daily making decisions about how to invest to try to improve the health of communities. Having answers to those kinds of questions is really very, very helpful.
Great. Well, Tony, I'm going to follow your lead and move beyond research to talk about what we need to be doing differently in practice, in systems and policy to tackle social determinants of health inequities. So I'm going to start with Paula again, and let's start with the healthcare system. And certainly there has been a lot more attention to health systems' role in addressing social determinants since the Affordable Care Act, including the expansion of Medicaid waivers to cover social determinants, CMMI's accountable health community model. Some health systems actually have directors of social determinants, and hospitals are adopting patient-level screening for social determinants. In fact, there was a study in Health Affairs that found between 2017 and 2019, health systems invested at least $2.5 billion on social determinants, most of which went to housing interventions, though some also went to employment, education, food security, social and community context, transportation. Paula, is healthcare moving in the right direction and we just need to do more of it? Or do we need to completely kind of reimagine what healthcare system needs to be doing around social determinants?
Well, this question makes me very uncomfortable. I have mixed feelings. On the one hand, I'm really glad that some communities benefited from some actions by some medical care organizations. On the other, for one thing, we have private for-profit medical care is a very important force in this country. That you're not going to see big, investments in communities from that, when the bottom line is, it is indeed the bottom line when it's about money. And, and what about the public sector, the public and the nonprofit sectors? I guess my instincts just tell me that they should be ferociously advocating for housing and education, and to stop to the school to prison pipeline, and that to play a role as advocates, to have these issues addressed by the institutions that are supposed to be there in a society. I'm always so jealous when Tony talks about growing up in Canada and having a safety net, we don't have it here, but we need we need to push for it. And I don't think that these kind of voluntary, charitable kinds of efforts that healthcare organizations are making, I think they're coming from in most cases, coming from a genuinely, humane place and caring. But I'm afraid that it's a distraction from the need to have a social safety net and these other institutions that address these other social determinants like housing and childcare, et cetera.
Thank you, Paula. Tony, I'm going to ask you a similarly uncomfortable question about our public health system. So is the CDC doing enough? Is the California Department of Public Health doing enough? Are California's local health departments doing enough to address social determinants of health? And if not, what differently should we be doing?
Well, the answer is a sort of unmitigated no. I think that part of it is that they feel the political constraints of the sort of their bosses are politicians, and they have very short-term kind of incentive structures. And the key to sort of, as Paula was alluding to around the healthcare system, is these are good people. They just operate under very perverse incentive systems,
right?
And they're behaving normally as any normal person would under that set of incentives. And that incentive, is structured around sick care. It's not around health. And similarly, in the with CDC, state health departments, local health departments, their incentive structure is a sort of short-term political set of incentives, that really is not tied to these long-term deep investments in health. Because if they were, again, they would read Elizabeth Bradley's, the American healthcare paradox, and they would see the answer, proven over and over again. Invest in social services and benefits, you get better health. If they cared about health, there's a blueprint for doing it. But they don't. They care about being reelected, and they care about essentially not being politically embarrassed. And this is part of the reason that we think that narrative is so important, because narrative actually creates kind of feathers the nest for good policy. And, when you have this sort of stark narrative that talks about, some group of people being rapists or, things like crack babies and super predators, that's a narrative that argues against investing in the social contract or the safety net. So I think that, part of the responsibility of organizations like CDC and, state and local health departments and schools of public health is to start engaging in the narrative space, which is very uncomfortable for them because it's not closely cleaved to sort of the academic, quote unquote, objective, reality. It's really fundamentally about what kind of society do we want to have. And once we can sort of start pushing the narrative on that, we can start legislating and making policy that's consistent with the kind of society that we want to have. That's not happening today. Whether it can happen or not, I think is up to sort of the leadership of public health, who just have to take those kinds of risks.
Thanks, Tony. Mahasin, a lot of people over the last couple of years have really jumped on the bandwagon of talking about dismantling institutionalized racism. But few of us who are trained in healthcare or in public health actually know how to get it done. How do you suggest that our nation go about dismantling institutionalized racism?
I was hoping you weren't going to ask me that. Well, first, I need to acknowledge that this is a very big question. And so I invite other panelists to weigh in on this question. But also, I think maybe there needs to be a part 2 of this series to really do this topic justice. But I guess I'll share a couple of thoughts. I guess first, to really tackle institutionalized racism, we have to be honest about its existence. We have to be honest about the historical insults that created the deep sort of rooted social hierarchies that exist. We have to be honest about the contemporary forms of racism. And I think although there's been this sort of conversation and national reckoning around structural racism with groups like the American Heart Association and the Centers for Disease Control and the American Heart Association, all sort of releasing statements or call to action to address structural racism, we also see tireless resistance towards teaching of, sort of how structural racism is operating. We see resistance in the form of teaching critical race theory. I think we're up to something like 42 states now that have some type of legislation being considered that's proposing to ban or limit the teaching of critical race theory in educational settings. And so we can't tackle racism without speaking truth to power. And then I guess the second comment that I'll make is that dismantling institutionalized racism can't come on the backs of the very groups that are impacted the most by these kinds of inequities. This has to be a shared responsibility. So what I want to continue to see in institutions like UC Berkeley, other academic institutions, hospital systems, educational settings, et cetera, is that we're working across race and ethnicity, across multiple identities, in a shared responsibility to educate, organize, sort of mobilize around, first of all, sort of being clear on the history, talking about the afterlife of slavery, talking about discriminatory laws and policies and practices and how they're patterning sort of current day social determinants of health. And it can't just be sort of on one group to really dismantle hundreds of years of oppression. And then I guess the last thing that I'll say is that the work that we're doing to quote unquote have a call to action around structural racism can't be performative. So we can't just do the education and just raise the awareness and just study the problem. We really need to have big changes to tackle and sort of achieve health equity. This is going to require resources. It's going to require intense investment in historically marginalized communities. It's going to require strong partnerships with the long-term residents of these communities so that they can be a part of deciding how this investment takes shapes and form sort of over time. And I think I'll stop there and see if any other panelists want to really weigh in on how do we tackle sort of institutionalized racism.
Tony, Paula, Ichiro.
Yeah, I very little to add to Mahasin's, beautiful description of sort of the work that needs to be done. There's a lot of collateral damage from racism. And I think that that's something that people don't understand. And that collateral damage manifests itself in the lives of all of us, including white people. And, Ichiro spoke about Angus Deaton a little bit earlier and his wife, Anne Case, and their work on deaths of despair. which is a huge epidemiologic phenomenon, on the scale of the entire US HIV/AIDS epidemic. And this is amongst white people. And I argue, mostly white people, I argue that that's the result of collateral damage from structural racism. This is essentially the lack of a social contract in this country has impacts, unintended impacts on white, typically lower income rural populations, but white populations in general, and the rest of us. So this notion of sort of racism is like this surgical laser beam that just hurts the people that it was intended to hurt is completely false. And ultimately, at the end of the day, this is why that sort of the cause of the cause of the cause is racism, because it's a very messy, sloppy way to kind of actually organize a society because of all these unintended consequences and collateral damage. So I do think that, and Mahasin said it beautifully, at the end of the day, we have to get back to narrative, the story of who we are, and the story of belonging, who belongs, because this racism is essentially saying you don't belong. And to the extent that we have, groups where there's, essentially there are tribal kind of competitions going on, we lack the social solidarity to essentially invest in our social contract and strengthening our social contract. And that has enormous unintended consequences, direct consequences, and all kinds of collateral damage.
Thanks so much, Tony. And Mahasin, I'm committing to part 2 of this conversation on dismantling institutionalized racism, because I really don't think that we're going to be able to achieve health equity in this country without really figuring out how to do that. But I want to ask Ichiro one last question before we open up for audience question. Ichiro, if inequality is harmful for your health, what are some policy solutions for addressing income inequality? And also just kind of love to hear your thoughts about policy solutions to income inequality from a life course perspective.
Sure. So fortunately, you don't need to ask that question of a social epidemiologist. If there is a political will to tackle income inequality, there are qualified people out there to answer that question, like economists. So, for example, President Biden's proposal to introduce a 20% tax on billionaires' income is a step forward, I think. And in answer to your question about early life course investments, an idea that has been floated is introducing the baby bond. Is an idea that was introduced by economists Sandy Darity and Derek Hamilton, in which every child receives a publicly funded trust fund at birth. And I think it's, this to answer Mahasin's, the question that was put to Mahasin, this has been proposed as one idea to try to close the racial wealth gap, which would have cumulative benefits across the life course, and might be a step toward reparations and toward addressing the fundamental economic inequities in this country.
Yeah, thank you. I'm just loving this conversation right now. It's certainly expand our thinking well beyond just having a social worker in the clinic to help patients navigate social determinants of health. Let me just ask Elise, are there questions in the chat from the audience?
Yeah, there are. And I think there's also just a lot of commentary about how powerful this discussion has been. And a recommendation for the book, The Sum of Us by Heather McGee. Both our student, Michaela Kupfer, recommended it, and then our alumna, Mary Pittman, said +1. So just wanted to mention that. And a good question that came in is, why does public health have a tendency to focus on individual level interventions despite an understanding of the role of the social and structural determinants of health? And what can we do about that?
it's easier. I mean, it's infinitely easier to focus on the individual and blame the individual when they don't,
I think it's starting to change, though, isn't it? So people are starting to think of multi-level interventions, which are interventions that address the individual, but also the context in which they work or lead their lives. And so, example would be some of the work done by my colleagues here at Harvard, like Gloria Sorensen has been doing some very impressive work to try to change the workplace context in order to change individual behavior. I mean, her WellWorks trial, randomized trial, very rigorous study, very impressive in that she showed that if you focus only on the individual by trying to persuade them to stop smoking and adopt healthy habits, it usually doesn't work, because if you ask the workers why they don't follow her advice, they'll answer her. They'll say, why should I stop smoking when I turn around and I get exposed to exactly the same carcinogens in my workplace? And so her idea was to combine that individual intervention with a workplace occupational health and safety intervention, which then changes the motivation of individuals to invest in their own health. And that's an example of a structural intervention in the workplace that goes beyond just trying to work on each individual at a time.
Great.
Yeah, I would just add that, I have the privilege of teaching at Berkeley with my colleague, Harry Snyder, who comes from the world of consumer advocacy. And, the traditional way that I was taught in medical school was that, health was really some product of genetics, behavior, and access to healthcare. And so I think that medical model is still sort of the primary model with which, public health kind of operates to sort of design interventions. And the recognition that we have in our work is that those three things are somewhat true, but largely wrong, and that health is in fact political. And that's horrifying to people who come from kind of the traditional sort of biomedical kind of scientific education. They just think that's, I'm not going to touch that with a 10-foot pole. I teach public health advocacy, which is essentially taking the tools of persuasion and translating the science of public health into policy that is enduring. And to do that, you have to understand how systems change, how decision makers learn, how information is translated from the, that sort of ivory tower into your neighbor's, context for understanding the world. And that is, those are political processes. Overwhelmingly. And if we don't embrace that in public health, we will be ineffective in making the kind of enduring change that we profess to be interested in.
The causes of the causes of the causes of the causes are political. We know that.
We got 3 minutes left, and Tony just got me. Yeah, I just have to ask this question, right? Because the four of you work in 3 of the top institutions in the world: Harvard, Berkeley, UCSF, right? So are we doing enough to educate our next generation of medical students, residents, public health professionals about social determinants of health? And if we're not, what should UCSF, Berkeley, and Harvard be doing differently?
UCSF is actually doing quite a lot and took a turn about, I don't know, whether it was 15, 20 years ago. And so is it enough? Probably not. But it does represent, I think, a major commitment from the leadership of the medical school.
Yeah, and I'm super proud to be an alum of UCSF. But if there's one thing, Paula, that you would tell UCSF chancellor to do, or the dean of medical education to do, what would that be around social determinants?
Well, I don't think I could answer that question. I think I'd have to think about that for a while. But it would have to do with creating awareness, more, the depth the depth and breadth of awareness and understanding about the role of the social factors, and that there are these long, complex causal chains, et cetera, so that they, at least when the issues come up, they're not obstacles to action on it. And at best, but that would be at worst, and then at best that they would become advocates for addressing the causes of the causes.
Ichiro?
Yeah, I think as elite institutions, we must do more to strengthen capacity in the low middle income countries. I think that's the leading edge of how social determinants will play out in global health. And I don't think that any of us do enough in training capacity to train students who come from LMICs and then who are future leaders in their countries. I know, that there are regions of the world, particularly Latin America, where there's a strong tradition of social medicine, for example. But I'm thinking of other countries like in sub-Saharan Africa, Southeast Asia, and so forth, where I know that they're still very much lacking in the social determinants kind of framework. They don't, they're not able to afford to come to elite institutions, and we don't really do enough in terms of trying to build capacity in those settings.
Mahasin?
Yeah, I think, what's happening at all these institutions is really outstanding in terms of the leadership that we are demonstrating around tackling sort of social justice, health equity, sort of incorporating anti-racist pedagogy, et cetera. But we also have to think about who gets access to this high quality education. So in addition to LMICs, what's the relationship between UC Berkeley and the surrounding communities in Oakland and Richmond, and our students that are coming from, these young, bright scholars who could teach us a thing or two about social determinants and structural racism? Are they gaining the access that they need to receive this high quality education? So I think we have to do more to strengthen those pipelines. And then I also think that we need to do more in terms of the representation that exists on our faculty, our staff, as well, in terms of making sure that historically marginalized communities are represented within our institutions and are in leadership within these institutions.
Tony, I'm going to give you the last word.
Thank you. It's an honor. I think that exposure to policy advocacy, I think when people are forged in the fire of these campaigns, and their lives are irrevocably changed. And I'm talking about physicians, I'm talking about public health students, the ability to sort of like organize a campaign to make a significant policy change that has public health impacts changes you forever. I see that with our students at Berkeley every single day, and they keep coming back asking for more. So I think that, when you see the sort of the power of effective advocacy, that your credibility as a scientist can be expanded in the public domain to make enduring change in the policy landscape, that is an awesome experience that I think more students really do need to have the benefit of.
Well, with that, I'm going to go ahead and close today's event by thanking all of our panelists. Thank you for such an amazing conversation, and thank you for your life's work on social determinants and your tireless fight, fighting the good fight for health equity, for social justice. And let me also thank our audience for joining us this evening. And please tune in for our next month's Dean Speaker Series on April 21st, where I will be talking with more innovators, changemakers, and arc benders of public health about the life course perspective. Thanks, everybody. Be well and be the change that you want to see in the world.